أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم. My dear friends, colleagues, students, actually I was talking previously about the dermatology is concerned, and I have given some tutorials for the basics of dermatology, because their dermatology, the field is actually nowadays practicing cosmetic dermatologists or interventional type of dermatologists, where some, they are using instruments, etc., etc. And some people are for the biopsy procedure, the histopathology, they are doing histopathology. But one of the field actually which was popular is clinical dermatology. Now, I'm talking about the clinical dermatology. And clinical dermatology means that you're a dermatologist, or if you are a dermatologist or whatever it is, then you has to be, aware of the diseases, systemic diseases, which manifest themselves, And this is what is this. This is sea shore. There is one thing is you go for the depth of the sea and see what are the structures and what are the organisms and what are the animals they are under the sea. This is the one way of to what is called the geophysics and geology. Part is one is concerned with the oceanology, the geo-oceanology, the geographical aspect, and one can deeply dive into the sea and then see the structures and then collect the specimens. This is one way. Another way is everything in the sea will actually come out at its shore. And we see these type of things are there. There are muds, and these are the clams, and these are sepia and other what they call pearls, etc., etc. Small, dead animals, etc. They are representing the depth of the sea actually, or inside the sea there is something going on. So it comes on the shore, and you can detect it from the shore. And that is why the dermatology, the systemic diseases, they represent on the skin. If they are represented on the skin as the sine qua non of the disease, meaning specifically, they are called the peripheral stigmata of the systemic disease. If one is missing these peripheral stigmata, then he will be not sure about the clinical diagnosis. He cannot confidently say what is the disease. For example, there is peripheral stigmata of the liver disease. There are peripheral stigmata of the chronic renal failure. There are peripheral stigmata of the diabetic neuropathy. There are peripheral stigmata of the diabetic autonomopathy, etc., etc. They represent on the skin, for example. So they are called the dermatological manifestations of the systemic disease, because it is a long run, because it was demanded by some of my students that often asked in the examination of MRCP, and some part of is asked also in FCP's examination. That is why they actually at one time, I was appearing in MRCP just for nothing. 40% of the MCQs, or would say BCQ, they belong to the dermatological manifestation of systemic diseases. They asked it in 40%, much part. And I actually have noted down this, and I argued with the Royal College of Physicians that why are you asking the 40%? That is much load on a student. Although I have actually done, I think, more than 75% correct. All right, no problem. But the thing, the importance is there. What is I am stressing on is the importance of the dermatological manifestation which occur because of the systemic diseases. It's a long run. So I have divided this session into, because of the small bits you can understand, otherwise you cannot understand. If you are interested, I don't know you are interested or not. My aim is to deliver knowledge, and I am delivering it. So I am Professor Ali Hazar, you know that. I am a facilitator, an honorary global professor of medicine without any name, fame, or economics. This is a free channel for everybody. Now, first our discussion of it, because very important are the collagen diseases, they are connective tissue disorders. The connective tissue disorders, if you are saying, then they are most of the diseases, they are parallel with what are called autoimmune diseases. For example, the lupus erythematosus, it may be the disquiet lupus erythematosus, which is separate than the subacute cutaneous lupus erythematosus, and third one is systemic lupus erythematosus. There are three types: clinically, or morphologically, or histopathologically. Now, first of all, is disquiet lupus erythematosus, that most patients have limited disease, limited to the skin, probably to the head and the neck is involved. Localized, it is a localized type of the disquiet type of lupus erythematosus, or localized type of erythematosus, but rarely may present as disseminated disease, rarely, potentially affecting any area of the skin. That is called disseminated DLE. It is actually the systemic, it is the conversion of the disquiet lupus erythematosus into the systemic lupus erythematosus. It presents as rash, which are erythematous patches. It's patch. They're describing as a patch, patchy type of, because no shape actually, and no sizes are similar to each other. They are erythematous, they are red color, with adherent scale over it. Some of the scales are visible. A rash which has got this particular features. These are particular features of this. In 14% of the cases, though they exhibit the Raynaud's phenomena. You know, the Raynaud's phenomena may be primary or it may be secondary. It is secondary Raynaud's phenomena because of the disease process, which is autoimmune in nature. Now, these are the things, they are definitely, they can, you can be asked in MRCP examination or in STEPS examination, and what is this? You see, this is a patches. You cannot describe it properly because there is no shape, no sizes. Some scales are present. They are red in color and or disquiet in shape, discus-like in shape, just like this, just like this, or this is the depigmented afterwards. They may cause depigmentation. Now, this is a very classical. Now, everybody would say that this is tinea capitis. No, it is not tinea capitis. But this is a lesion which is irregular margin, and the other one is some other part of the head. They are not similar to each other. They are red in color, and there are some scales. Few scales are present. It is not psoriasis. Psoriasis are a lot of scales, shining type of scales. Other than this is another picture. It is shown, and this is around the mouth, and this is a patch. This is a patch. This is a patch. All are different type of patches. In the same fashion, the other lesions are describing on the different parts of the body the same one, like this. Yeah, on the lips, with the skin attached with the mucous membrane here, you find. Now, localized DLE, that is quite linked with erythematosus. Localized type face is most commonly affected area, followed by scalp, ears, arms, legs, and turns to a lesser extent. Not disquiet, localized. Disquiet erythematosus rash appear most commonly over the cheeks, bridge of the nose, ears, scalp, and the side of the neck. With limited disease, that about the limited, it is a localized one. And it is associated the rash is same one, it is quite all the same one as the previous one, and it appears on the cheek and the bridge of the nose, upper part of the body. Alopecia occurs in 1/3 of the patient. This is association with alopecia also. So this is a what is called a scarring type of alopecia, because the roots of the hair is gone and replaced by the fibrous tissue. Now this is localized. You see this as in this patient, a big one. It is erythematous, now scaled. Now it is changing its color. Here it is on the scalp, and it is on the upper arm. This is very, very big lesion. Scales are there. It is not shiny scales, very shiny. Small scales are there. They end up as a fibrotic lesion afterwards. Now, disseminated discoid lipus produces characteristic lesion of the DLE may occur. These type of localized or it is focalized. Now, the disseminated widespread pattern are seen on the tongue and the limbs. This occur almost always in the women, and they are cigarette smokers. Mostly association are cigarette. They are smokers. So widespread on the tongue and the limbs, this variety tends to be persistent, resistant to the therapy, and associated with this psychological upset. The dissemination means they are now it is now moving into the systemic lupus erythematosus. It's the same one, disseminated or systemic. Now, skin manifestation occurs approximately in 80% of the cases. Butterfly rash, most commonly 51, facial edema, then subcutaneous, lupus erythematosus. I have already described. I will be describing it afterwards. Chronic disquiet, chronic scarring DLE with alopecia. Non-scarring alopecia may be possible. Chilblain lupus means chilblain means it occurs on the lower limbs. It is very sensitive to the winter seasons, and it is the mouth ulceration association and the bullous eruption. These are the manifestations. And photosensitivity is 63% common. Renault phenomena is 60%. Chronic urticaria is 44%. These are common ones. Cutaneous, vacuous, libido, reticularis, and episcleritis, and the other one are there, chilblains, etc. They are rare, although percentages are shown in front of you. Now, cutaneous erythema on light exposed area is the most common feature, that is photosensitivity rash. Butterfly blush with a fine scaling on the butterfly area of the cheeks is frequently found, and epidermal necrosis may occur in some cases. And alopecia occurs in about 50% of the cases. Hair becomes coarse, dry, and fragile, called lupus hair. Persistent, non-itching urticaria like beetles are common. Just like beetles, the urticaria, non-itching. Libido reticularis is the mottle of the bluish red discoloration which branches on pressure and is not affected by the temperature changes, may develop over the outer aspect of the arms. Libido reticularis can occur in the lower limbs also. Now this is the diagnostic criteria of SLE or disquiet, or the disseminated lupus erythematosus. It should be malarial, there will be disquiet rash, photosensitivity. There 3 are the skin lesions out of 11. Oral ulceration is a part of it, and non-erosive arthritis and serositis, or maybe a renal disorder. Maybe you can demonstrate it. It is 7th one, and 8th neurological disorder, and the other one hematological disorder. Any type of the hematological change can occur. Immunological disorder like LG cell phenomena, anti-developmental ANA, etc., etc. A lot of antibodies are present in the SLE. It is the only disease in which a lot of antibodies are there. And anti-nuclear antibodies should be present along with the other antibodies, with 11. So out of 11, you have this is the criteria which is described in front of you. And this is called tense criteria. So out of this whole, should be at least 5 to 6 should be positive to diagnose systemic lupus erythematosus. It may be some part of the clinical, pure clinical, this one. But these are the lower down 7 to 11, they are diagnosis of the immunological examination or the hematological examination. The 10th criteria. Now here is you see this is the very butterfly rash, and you find this is the lesions there, and these are the patches are seen here on the lips, and there photosensitivity rashes are demonstrated in this here, and the balance alopecia, and this one. It is the scarring type of alopecia, and the look this is a Reynolds phenomenon which is showing here. So out of these 11, you have to actually, it should be demonstrated at least 4 to 5 before diagnosing it. It is American rheumatological criteria. Another disease is scleroderma. At first, lesions are indurated and faintly purplish. Later, they lose. This is systemic sclerosis actually, especially in center, and appear as thickened waxy areas with smooth and shiny surface. Hairs are usually absent over these surfaces. Another part of this lesion is morphia. That is, the patches of the hardened skin appears over the face, hands, and the feet, which lacks sweat gland and ability to make skin folds. Morphia. Another one is skin duration. In duration, initially affects the fingers, that is called sclerodactyly, and extent proximally. Reynolds phenomena is a common finding. An infarction and a dry gangrene in the fingers may occur sometimes due to the severe vasospasm because they exhibit the Reynolds phenomena, or else this is a type of vasculitis actually you are discussing. Now here the sclerodactyly is seen here, and this is this is all our red area. The scales are present, and there is deformity developed because of the fibrosis. And here is the long vasculitis. This is the gangrene of the vasculitis. Again, it cannot extend or properly for the prey sign is concerned. May be associated with the carpal tunnel syndrome. Here is these are deformities which are shown here, and this is she cannot smile properly because of the fibrosis. She cannot open the jaw properly. And here the other one is these are the lesions which are shown. They got hard skin, dry skin, and these are shown. There are characteristic features of the scleroderma. Although there are many types of the systemic sclerosis or scleroderma, I will discuss it when I will go through the autoimmune disease. Another dermatomyositis, a purplish red or the heliotropic erythema occurs on the face, especially involving the eyelids, the upper cheeks, forehead, and temples. Edema of the eyelids and the periorbital tissues may occur in dermatomyositis. And small erythematosis or villous fat papules called Gottron papules occur over the knuckles and the dorsal of the finger and around the nail folds. But I was taking the last time this examination in Islam, a patient with dermatomyositis, polymyositis was presented by the administrator to the examination hall. Actually, the students were confused with these Gottron papules. One student came and said that it is this and this and this, and they got the flat papules, the Gottron papules, knuckle, etc., etc. Actually, he has already seen that case. So I turn out to be, actually I 100% 180 degree turn afterwards. And I usually, how will you examine the skin? What are the parts? How will you describe a lesion? Etc., etc. I asked this to that student, and he was unable to answer. As far as the dermatomyositis is concerned, I deeply, asked this condition because he had learned properly from every book. So he answered it. Everything, the signs, etc., clinical signs, etc. 5 skin features are improperly heliotropic rash over eyelids, seldom seen in adults, and cotton papules, villaceous erythema over metacarpal phalangeal joints, peripheral interphalangeal joints, metacarpal joints, metatarsal joints, knees and elbows, and V-neck rash, that is the shawl sign, villaceous erythema, anterior chest with telangiectasias. Now, periangular erythema means that here this is erythema, and calcinosis are seen in the peripheral parts. Now, this is demonstrated the heliotropic rash. It is not shown. This part is actually villaceous reddish. It is because the light is reflecting. We cannot comment on this. It seems to be reddish, no reddish. This part, look this part, look this part. Remember this part, and this part here. Now compare it with this. The heliotrope flower. This. Now again, see this. Now this is, you see in the naked examination that this one. It's very near to the heliotrope because it's reflecting, because it is a film. You cannot comment on the heliotrope flower because the candidate which I was actually have been examining, he was examining the patient and he said the heliotropic rash and everything. Actually, the students consider the examiners, most of the examiners, they are not up to the date. Or they are not so much intelligent that they pick up those students who have already seen the case, who already discussed the case, and who only actually by heart they remember everything about the case. 180-degree turn will occur. It will not benefit the student. Now it will be the horrible instances afterwards, because they will say that it is poor performance, although he diagnosed it properly. So this is about the heliotropic eruption. Here, this is shown here, actually is reflecting. And cotton papules at this one. You see this on the distal interphalangeal joints, the peripheral interphalangeal joints. It is a large amount seen on this, under the nail also here, and also here. Shawl sign is seen in this condition. And that candidate said that she is suffering from shawl sign. Because she was a lady, I cannot examine properly, forget the shawl sign. What are the causes of this type of a sign, other than dermatomyositis? This was a question I asked the candidate. But rheumatoid arthritis is a very famous condition. Rheumatoid nodules, these are the subcutaneous nodules affecting the extensor surfaces of the forearms, back or hand, occipital region, articular region more commonly. Cutaneous small vessel vasculitis may lead to the purpura, bruise, or ulcerative lesions over the skin. Another lesion is important is pyoderma gangrenosum, sterile pustules which rapidly evolve over the painful ulcers characterized by raised edges with erythematous papules covering it. Now these are shown here. See that these are the rheumatoid picture here, and here in this condition you see the nodular lesions are seen, and the joints are involved. This one, very near to this, and other things are the erythema which is going on here and there. Now this is the deep studies of this rheumatoid nodules, cut sections shown here, and other things. They have enlarged this one and show these lesions are concerned. Now, actually, non-specific cutaneous manifestation of the rheumatoid arthritis are the diffuse cutaneous atrophy, that is interphalangeal joint atrophy, edema, bluish coloring of the fingertips, palmar erythema, axial cutis laxa. The axial part is the laxation is there in the skin, and the round phenomena in the chronic lower limb ulcers, spontaneous chronic urticaria, urticarial vasculitis, and the cutaneous ulcerations are seen as a vasculitic phenomena, like this one. If vasculitis occurs, then definitely there is edema, and then edema, that is Lewis sign, and then it is gradually, caving out, and it is then replaced by the chronic inflammation. Try to replace it, and the fibrosis. But if the vessel is completely vascularized or it is thrombosed, then of course lesion, it is going to be a necrosed lesion. Then afterwards, here it is seen on the lower limbs. You see, these are the rheumatoid nodules along with the other part of it are seen. Erythematous type of rashes are seen. These are the non-specific type. So, only thing of the rheumatoid arthritis is concerned, actually, these are bones, the joints are involved. Nodules are seen elsewhere also, in other diseases as well. You have to differentiate between these two. Specifically speaking, these are present only. Otherwise, the cutaneous vasculitis is concerned, the ulcerations are concerned, the erythema, they are non-specific signs. Urticaria associated with the arthritis is common, and IgE levels are much higher in this condition. I have seen many cases with IgE levels of more than 2,000, 3,000. And there was a question of mine, why it occurs, 3,000. And then I actually referred to the case of rheumatologist. He said that it is a skin condition. Why you are referring me? And this is the open challenge to everybody. I'm very sorry about my colleagues that they have not, I think they have not trained like this. Because IgE levels of 2,000 with skin lesions. And there are other visions, other systems are involving also. She was, very much depressed lady, which I have seen, I think, 3 weeks before. Chronic urticaria associated with the joint involvement, associated with some part of, erythema on the fingers. And IgA levels are more than 12,000, 10,000. Remember, this is much, much higher levels, loaded in the blood. So what is the condition then? I referred to the rheumatologist. She said that no, it is you have to refer to the dermatologist. And I go, oh my God, ESR is 100, everything is in front of you. Why you are referring to the dermatologist? It is the rheumatologist who will see this case. Then they say that okay, fine, we will manage this case. Otherwise, I can manage myself. Why not? I'm internist, I can do it. But I referred that case. So this is the first session which I have delivered to you. There are 3 more sessions which I have to complete in 1 to 3 to 4 days. And then these are the systemic manifestations, the actually cutaneous manifestation of the systemic disease. There another topic are the cutaneous manifestations of the systemic disease, the systemic manifestation of the cutaneous disease. The reverse of it can also be possible. I'll discuss it later on. Assalamu alaikum wa rahmatullahi wa barakatuh.